Hello, and welcome to another podcast. Today we're going to continue with medications, and we're going to look at the old reliable green whistle, methoxyflurane. Now, methoxyflurane's indication is obviously for acute pain, but it might surprise people to know that it's not a popular drug globally, and it's only really used in Australia, New Zealand Defence Force and ambulance services, in the UK as well. But really, it's Australia and New Zealand that are keeping methoxyflurane alive. It was invented nice and early and heavily used in the 60s as a inhaled anesthetic. It was discontinued use completely in America in 1990s, I think 1999, but it still has use in Australia. And recently, in the last 3 years or so, the Europeans have started to look at the effectiveness of methoxyflurane as pain relief in emergency departments. So you may talk to international colleagues when you get to work with them, and they reasonably wouldn't have actually heard of methoxyflurane before. As to many of our emergency departments, people work in hospitals, it's quite a foreign drug, often dedicated to the pre-hospital workers only. But looking at its pharmacokinetics, it is quite difficult to get data on, obviously because a lot of the data is associated with it as an inhaled anesthetic. But we know that it is very fast acting, but has a very slow metabolism. It is highly fat soluble, and it distributes pretty much throughout the body and travels in the bloodstream. It's a large molecule, so it needs to go through extensive metabolism in both the liver and metabolism in the kidney, and that breaks it down to a bunch of metabolites, including fluoride. Now, as far as excretion goes, some of it is exhaled and basically unchanged, but the rest of it goes through extensive metabolism and then is excreted in urine. As far as its pharmacodynamics go, it's a little bit unique. So overall, methoxyflurane is used to reduce the excitability of the action potential. So this is mostly prevalent in muscle tissue and pain receptors, and it does it by, similarly to other things, it blocks neurotransmitters and it blocks electrolytes from passing on an action potential within the synaptic cleft. We also know that methoxyflurane is very active on the calcium-dependent part of ATP synthesis in the sarcomplasmic reticulum. Now, what that means is in the muscles, if we remember, the muscles sarcomplasmic reticulum are responsible for infusing a huge amount of calcium into the muscle in order to sustain the contraction. And it's the reuptake of this sarcomplasmic reticulum that is mostly associated with heat gain. So it binds to this, and it's this affinity with this calcium-dependent line that actually links to the condition malignant hypothermia, which we can talk about in a little bit. Methoxy has also been known to bind to GABA receptors, so it has that inhibitory response of GABA. And all in all, we don't really know how it reduces the excitability of the pain receptors. We just know that it actually does. Now, adverse effects are quite huge with methoxyflurane. There's a reason it's been discontinued use across the world. It's nephrotoxicity. So we'll talk more about nephrotoxicity when we look into clinical take-homes, but just know that an adverse effect is nephrotoxicity, and it can happen to patient and treater alike. But generally speaking, you can get altered level of consciousness, because that's sort of the idea in that relaxation phase, is they tend to get a bit drowsy, but that lack of consciousness can lead to a reduction in airway control. Okay, so it's particularly important if you're dealing with someone with a head injury and you give them methoxyflurane, it's more likely to occur. The most common adverse effects that we see with the doses that we give is coughing and someone getting a headache afterwards. As far as true data, as in statistics on adverse effects as used as an analgesic, there just isn't enough. Maybe after the trials in Europe will get some more data, but for now, there's not enough. There's a lot of anecdotal, people are using it, knowing what's going on, but that's pretty much what we have. As far as contraindications go, we've got allergies to all allergens and also your fluoride-based medications. If someone already has an altered level of consciousness, you don't use it. If someone's got a history of renal or hepatic impairment, then it's best not to give methoxy as well. It's very taxing on the liver and obviously, as I mentioned, can be highly nephrotoxic. It's also the case that if somebody is known to suffer from malignant hypothermia, basically they'll know because they've had surgery before and they've had malignant hypothermia, that's pretty much the only way to know, is this drug is completely contraindicated for them. They are quite rare though. Okay, finishing with some clinical take-homes. You'll read in a lot of protocols that the max dose is 6 mils a day. So nice and easy, you give them 2, and that's usually enough. But they often write that you're not to give somebody more than 15 mils per week. Now, there's a good reason for that, even though you think logistically, what poor bugger is going to be in a situation to have full doses of methoxyflurane 3 times in 1 week. It's not a drug that we often use in hospitals for ongoing pain relief, so it never really seemed feasible for somebody to get 15 mils of a dose in a week. But that also plays true for you as a treater. Even though you're not getting the full amount of the methoxyflurane, if you're giving methoxyflurane out regularly to patients and you give each patient 6 mils, and then you couple that with that patient being in the back of a vehicle, then the effects of methoxyflurane can accumulate, as can the nephrotoxic effects accumulate on you and the driver. So to this extent, before carbon filters came out and became pretty popular around the ambulance services, a lot of ambulance services would have protocols that basically governed how many methoxyfluranes they could give in a shift and a week in order to minimize the effects of methoxyflurane. Now, if you're part of an organization that doesn't have the carbon filters, then work and encourage to get them because they do exist now. But if you don't, then just keep it in mind. Protect yourself, protect your drivers, do the best that you can to minimize the secondary exposure of methoxyflurane, because whilst it's often not enough to get you euphoric, it can be enough to cause nephrotoxin in the long term. Now realize that methoxyflurane, whilst being a very good analgesic, it does take 1 to 2 minutes to kick in for the analgesic effects. So we often use methoxyflurane when we're going to do something painful. It gives the patient control of their pain relief, gives them a memory peg to distract themselves, and it's effective as well. So let them have a few doses beforehand and then look at moving that fracture or moving that patient. Okay, so just plan your treatment accordingly. Realize that methoxyflurane is a great drug to be coupled with other analgesics. It doesn't have to be a one-stop shop. You can give some methoxyflurane early whilst you get other things going, and then you can titrate their pain relief with opioids, ketamine, whatever else you want to manage that patient properly. Realize that a lot of patients don't actually know what methoxyflurane is, and they think the green whistle is in fact the drug itself. So use that to your advantage. If somebody's already had the 6 mils and they're holding on to that whistle, don't tell them the whistle stopped working. Just let them keep the whistle. Let them keep breathing on it, give them something to focus on. And it's amazing how much pain relief or distraction realistically a patient can get just from that whistle itself. Now realize that it works by having to breathe in the actual drug. So you have to deep breathe it in. So if someone's got significant fractures to the ribs who can't take a deep breath, methoxy is not a very good analgesic, and you need to rely more on your opioids. Same too, if your patient needs oxygen, then they need oxygen. That takes the precedence, and we use a different analgesia. Don't get into the habit of thinking that sticking the oxygen tube on the back of the green whistle is useful for the patient as far as oxygen goes, and it also blows off a lot of the methoxyflurane, which means your dose doesn't even get into the patient. So always keep that into account as well. Okay, that's it for good old methoxyflurane. Nice and quick one. I hope you got something out of it, a bit of appreciation for what methoxyflurane is. But until next time, take care.